Thank you very much. Thanks for the very kind introduction, and thanks for the invitation. It's great to be here in this amazing city, and it's great to talk about vasculitis. So my main interest is in ANCA-associated vasculitis, so I'm going to focus on that aspect. The title is not necessarily easy, and I'm going to show you now I decided to approach it. So I'm going to provide you my selection within the abstract submitted and accepted to the American College of Rheumatology Society this year. I'm going to try to contextualize a little bit the findings of this abstract within what's hot and what's interesting and what's going on in the field of ANCA-associated vasculitis. So we'll see where we get. The first highlight I'd like to present regards this study. This is a study performed in the mouse, so it's nothing related to human, but it poses the idea of a further therapeutic approach that may be available in the future. So in this study, mice were randomized and were treated with controls with normal mesenchymal stromal cell or mesenchymal stromal cell therapy that were developed with combining them with cytokines and specific growth factor. The idea here was to see if this approach was able to improve the control of diffuse alveolar hemorrhage in these mice, and it worked nicely in order to reduce the percent of hemorrhage, reduce the lung bleeding, reduce the histologic erythrocyte-induced inflammation. So this is something that is far away from being employed in our clinics, but it's something that it may end up there in the future. Another bit of interest that has been focused on biomarkers. We are always looking for new biomarkers. We know how key are for the management of our patients and for stratifying the disease severity and the therapeutic approach of our patients. This study focused on 78 patients with ANCA-associated vasculitis. Some of them had active disease and some of them had not. What they did find, they did identify in an unbiased proteomic approach some molecules like tumor necrosis factor superfamily 14, oncostatin M, FMS-like tyrosine kinase 3 ligand, as able to identify patients with active disease. And these were performing even better than some, biomarkers we use in common practice like white blood cells, platelets, CRP, and ESR. Another interesting piece of science was focusing on biomarker in kidney biopsy of ANCA-associated vasculitis. We do know that the kidney biopsy is an important tool in ANCA-associated vasculitis, not only for diagnosis, but also for prognosis of our patients. So here the investigators did something more. They performed all tissue RNA sequencing in 22 patients with ANCA-associated vasculitis and try to identify biomarkers. They compare the biopsy of these patients to biopsy of some control. They did identify some biomarkers that were actually highly expressed in the tissue of patients with ANCA-associated vasculitis. Most of them were associated to the classical and alternative and common pathway of the complement, and some of them were receptor of some anaphylotoxin like C5a receptor, C3a receptor. Of course, there's a lot going on in terms of therapeutic approach targeting the complement in glomerulonephritis and in immune-mediated diseases. So this poses a further rationale for targeting the complement in patients with ANCA-associated vasculitis. I found also interested with this abstract provided by the French group regarding the role of the induction regimen employed in a GPA and the outcome. This is a big trial, relatively big trial, the REOVAS trial, that compared patients with the GPA. They were stratified according to the 5-factor score and then were treated with rituximab or with conventional treatment. Conventional treatment was balanced according to the severity of the disease. You can find on your right the patient's characteristics that were overlapping nicely. What they did find is they confirmed the finding of the main study, no difference in terms of major and minor relapse-free survival between the two groups. But if you focus on the Kaplan-Meier on the panel C and the panel D, these are only the patients that were MPO-ANCA positive. And they did find that the patients with a GPA and MPO-ANCA positivity did a lot better if they were treated with rituximab-based induction rather than conventional treatment. You can see on the bottom of the Kaplan-Meier that the numbers are small, but still the difference is significant. And this is in keeping with our evolving understanding of EGPA. This is the first genome-wide association study we performed while I was in Cambridge on ANCA-associated on EGPA. And what it was found was that the genetic background of the GPA was significantly different compared to the ones that were MPO-ANCA positive and MPO-ANCA negative. This replicates our clinical experience in dealing with the disease, and the association for the MPO-ANCA positive ones is the same HLA-DQ that is associated with the MPO-ANCA positive AAV, what we call MPA, suggesting that there's a strong biological rationale for considering MPO-ANCA positive EGPA something tightly related to MPO-ANCA positive AAV. This is another abstract that interested me a lot regarding the role of hypogammaglobulinemia in the AAV. This is a monocentric experience of 98 patients treated with rituximab as maintenance therapy. They did identify that the IgG level reduced throughout the follow-up, and for a proportion of patients, this reduction was quite significant to begin with, as you can see in the yellow curve. Was quite significant to begin with and then remain lower during the follow-up. They did identify that risk factors to have significant hypogammaglobulinemia that they define as a decline higher than 25% and gamma globulin level lower than 6, where age higher than 60, baseline gamma globulin levels lower than 10, and use of pulses of methylprednisolone at induction. And having these characteristics, so gamma globulin lower than 6 and a drop higher than 25%, and having received methylprednisolone at induction were associated to an increased risk of infection. And this replicates further what we now understand better in terms of the role of IgG and hypogammaglobulinemia in ANCA-associated vasculitis. This is our experience of our 227 cohort we have collected within the European Vasculitis Society. These patients received rituximab as induction. What we did find were that the patient that experienced severe infection within 6 months after rituximab administration had lower IgG level. And the factors associated to have low IgG level, defined for this study as lower than 7, were older age and a higher dose of prednisone employed at the moment of the induction. This has been replicated also in other ethnicities. This is a Japanese experience showing that the patients that would develop IgG level lower than 500 within 24 weeks from the induction were more likely to develop severe infection in the further 48 weeks of follow-up. And this was independent from the induction regimen employed and was influenced by the prednisone dose employed. So once again, things in common. And these are the risk factors of developing hypogammaglobulinemia in the rituximab trial, which show that higher glucocorticoid doses and lower IgG level to begin with were the main risk factors. So we have now a nice story here, a better understanding of what impact the role of what impact the risk of hypogammaglobulinemia, age, a glucocorticoid dose, having a low IgG level to begin with, and the fact that the IgG level are clinically relevant in terms of factors associated with infection, at least during the first year of treatment. So a lot of the abstract focus on the role of the complement on ANCA-associated vasculitis. Of course, this is a hot topic right now, so it couldn't be anything different. And we do know now, I don't want to you know, steal the field to some of the speakers that are going to follow me, but of course this is an important thing we need to discuss about. So complement in ANCA-associated vasculitis has been found as a central in the pathogenesis of the disease, in the pathogenesis of the inflammation, in the pathogenesis of the kidney damage, and in particular, it seems to be central, the alternative pathway of the complement and the C5, C5a, C5a receptor axis. These, in collaboration, as you can see, with the neutrophil, create a sort of a fueling of the inflammation in the ANCA-associated vasculitis. So at the ACR this year were presented some of the advocate sub-analysis that were interesting in order to better understanding the role of avacopan, of this new drug targeting the C5a receptor in the management of ANCA-associated vasculitis. Briefly, what is advocate? I think I need to give you a little bit of coordinates for who may not know the trial, just to explain better the abstract I'm going to show you later on. This is a study where patients with the active disease receive rituximab or cyclophosphamide and high-dose glucocorticoid as induction. They were then randomized to receive avacopan 30 milligram twice a day and to taper down to 0, ideally, the glucocorticoids in 4-6 weeks, or 60 milligram in prednisolone. The second group tapered the prednisolone down to 0 at 20 weeks, and the main outcome were at 26 and 52 weeks, and were remission, defined as BVAS of 0, and no need of steroids in the weeks before. What it was found was that the avacopan group was non-inferior to the glucocorticoid group at 26 weeks and was superior at 52 weeks, with a better profile in terms of relapse-free survival. The avacopan group ended up in receiving lower glucocorticoid dose, 1/3, not 0, but significantly lower, better scoring in terms of quality of life. And the study was therefore a positive study indeed. What it was interesting in patients with renal involvement, the study showed that the slope of improvement of GFR, at least in the subgroup with a severe involvement, the GFR lower than 30, was better in the avacopan group compared to the prednisone one. And this seems to be maintained from week 26 to week 52, and the two curves seem to open. So, having introduced the study, I'm going to show you some of the sub-analysis of the studies that have been presented at the ACR. This one by Ulrich Speck focused on the patients with diffuse alveolar hemorrhage included in the study. As you can see, only 12 patients. Patients with severe diffuse alveolar hemorrhage needed mechanical ventilation were not included. So these are all patients with alveolar hemorrhage that was not defined as severe. 5 of them were in the avacopan group, 7 of them were in the prednisone group. What it was found was that even in this context of relatively high severity, avacopan was able was associated to a lower exposure to steroids in the first month of treatment. All patients had their diffuse alveolar hemorrhage in remission by week 4, and the remission rates throughout the study were good. This is probably the most interesting piece of information that has been provided during the ACR meeting and focused on how albuminuria changes during the advocate group, during the advocate study. So, as you can see, the patients receiving avacopan, the one in blue, had a significant drop in proteinuria, which is very quick. And as quick as 4 weeks, this patient has a 40% reduction of urine albumin creatinine ratio, which, as you can see, is significant. And in the end, the glucocorticoid group would catch up at 13 weeks. This may give us the idea that the drug is very effective in reducing the inflammation in the kidney relatively quickly, and may be the rationale to explain why the patient treated with avacopan had a better improvement of GFR compared to the one treated with glucocorticoid. These other sub-analyses focused on the renal involvement and quality of life in the ADVOCATE trial. So it was focusing specifically on the patients with kidney involvement to see if what found in the general population in terms of better quality of life, lower glucocorticoid toxicity was replicated also in this context. And indeed, it was the case. Other sub-analyses, I haven't included them just for sake of time, but it was confirmed safety and efficacy in the subgroup receiving rituximab as induction and safety and efficacy in the subgroup older than 65 years. What is also interesting, some early experience with avacopan have been shown, or we do know that sometimes we have discrepancy between clinical trial and real-life experience, so we do need real-life data. These are data from the US, including 12 hospitals, and the prescription of avacopan, as you can see, in 1 year and a half. 66 patients were included, although only 56 at the end were treated. These were mainly patients with MPO-ANCA vasculitis, mainly with new diagnosis of the disease, and the prescription setting was mainly as an outpatient. As you can see, renal involvement in 36% of the patients. What they did find that the avacopan had a median time of discontinuation of 56 days. The median time on avacopan was 159 days. The drug was discontinued in 19 patients, 34%, more often for completion of the intended course. And this was, in 8 cases, happened at 6 months. So different, slightly different from what happened in the trial, that the treatment was continued for 52 weeks. Avacopan was discontinued by 5 patients, 9% because of adverse events. And you can see on your right that the proportion of patients on glucocorticoid tended to reduce during the follow-up, although not all of them were able to reduce the glucocorticoid. This is in keeping with the trial. The trial showed that the avacopan group received significantly less steroid, but not a proper steroid-free regimen. And the median value of glucocorticoid, the line in orange, reduced over time, but remain appreciable. So 10 patients experienced flared.
2 minutes.
Sorry?
2 minutes.
2 minutes, okay. 10 patients experienced flare. 5 of them were on prednisone, 5 of them were off prednisone, and in all cases, the flare were managed increasing the dose of glucocorticoid. This is another publication on real-world experience with avacopan, focusing on 80 patients with ANCA-associated vasculitis. Follow-up was 52 weeks. And once again, interesting real-life data showed that, as you can see, after avacopan initiation, GFR improved, proteinuria reduced, the glucocorticoid exposure was in keeping with the trial, and the drug was stopped in 25 patients, 31%, 14% after completing the 52 weeks of treatment, and 18% before the 52 weeks due to adverse events. So we are starting to have a feeling here on how the drug is going to behave in a real-life context. This is a poster I presented together with my friend Carlos Alvarani. I actually presented it at the American Society of Nephrology, and he did the same at the American College of Rheumatology. So we share, the burden here. This is the experience of 19 patients treated within an early access program with a longer follow-up than 52 weeks. So it's the first publication following on patients with a longer term follow-up. The median time of treatment was 17 months, and the main outcome here was safety. Only 2 patients within these 19 had severe adverse events. These were due to a flare of psoriatic arthritis in 1 patient and malaise and COVID-19 infection in another patient. The first patient also experienced a flare of the disease, and this was due to a temporary reduction of the avacopan dose due to troubles in supplying the drugs. So, what to take home? For sure that we have new therapeutic options that are still at preclinical stage, like mesenchymal stromal cells, that may end up being useful in the future, we don't know. We have good attention on biomarkers that are always needed, always useful, proteomics and RNA sequencing in the tissue. We have further insight in the classification complexity of EGPA, as well as the impact of hypogammaglobulinemia in AAV patients, and some interesting real-life data and further sub-analysis of the ADvocate trial focused on the avacopan. I'd like to thank you for your attention, and I don't know if it works, if I'm supposed to have questions now or later. Okay, thanks.